Sir, Sudhir Kotari, sir, and Yumas, sir, told they are joining shortly, sir, in 2 minutes' time, sir.
Perfect. No issues. Let the people join and
Sir, good evening, sir. Arun.
hi, Arun.
Sir,
Good evening, Arun.
good evening, sir.
Sudhir Kotari, sir, has joined, sir.
Hi.
Evening, sir. Welcome, sir.
Hi.
Thank you for being here today, sir.
No, thank you for inviting me.
Hello, sir.
Hi. Very good idea. I was just talking to Bhuvan, what scales, but then when he told me, I think all these scales are very important, and my suggestion is to just my suggestion is to have the thing, cataloged so that if somebody wants to see any scale or anything, we'll be able to find it later. Just now, all the subsections are having webinars, and we don't know which one is having what. So we'll try to see so that we can search on that basis. What is the talk on? It should not just be saved as subsection talk 1 or talk 2 or talk 3 like that.
Yeah, by the name, yeah. Makes sense.
So whose idea was it to call it Pathshala?
Everything done by Guan.
Ah, very nice idea.
Thank you, sir.
I only instigated him that there should be something like this.
Oh, you instigate everybody, Baba. So I am going to be running fast. I'm really jet lagged still. I just came back from US day before, but I'll inaugurate it. Huh?
Sure, sir.
7-5 you start.
Okay,
Yes.
sir.
Yes. AI assistant को भी नाम दिया मनदीप कौर, huh?
Yeah.
Good idea.
Yumas, sir, has also joined, sir.
Perfect. You start now.
Okay, sir. Good evening, Yumas.
Good evening, Nirmal sir. Good evening, P.
Good evening, Rajnikant ji. Namaskar.
With the permission of the Presidium and Chair, can we start the session, sir?
Go ahead.
Thank you, sir. Good evening, everyone, and welcome. Welcome to every single one of you from the great cities and the smallest towns of this country. And today, from 13 nations across oceans and time zones and the late hours of the night, wherever in the world you are sitting tonight, you are home. This is a word in this land that's older than almost anything we can name, Pathshala. Pathshala, it's older than our hospitals, older than our universities, long before there were lecture halls, before there were screens or slides or certificates. There was only this one who knew sitting beside one who longed to know, and between them, knowledge moving, not bought, not sold, but simply given. Passed from hand to hand, heart to heart, the way one trembling flame lights another and loses nothing to self and leaves the whole room brighter than before. For 3,000 years, that flame has never once gone out. Empires have risen and crumbled. Whole languages have been born and forgotten. And still, quietly, faithfully, that lamp has been carried forward. Today, it is placed in us, and tonight, together, we light it again. On behalf of NeuroRehab subsection of the Indian Academy of Neurology, with a full and grateful heart, I welcome you to the very first inaugural session of the NeuroRehab Pathshala, our monthly teaching series built on 3 words that will be our compass to everything we do here: learn, discuss, and measure. And today, myself, Dr. Guhan Ramamurthy, and this is the place I want to be here in the world with you all tonight, right here in NeuroRehab Pathshala. Every Pathshala has its guardians, the one who carried the lamp before us so that one day we might carry it for others. And tonight we are not merely honored, we are humbled to the bottom of our hearts to have with us the very leadership of the Indian Academy of Neurology. It is the privilege of my life to welcome and invite onto the dais of this presentation our president, the steady hand and the steady heart that guides our academy, Dr. Lakshmi Narasimhan Ranganathan, sir. It's a great pleasure to welcome you, sir.
Thank you.
Our president-elect who carries our academies tomorrow within him today, Dr. Sudhir Kothari, sir. We welcome you, sir. And to the ever-energetic secretary whose quiet, tireless devotion holds this entire institution together, Dr. U. Meenakshi Sundaram, sir. We welcome you, sir. And presiding over this evening as our chairperson, a past president of the Indian Academy of Neurology, and a man we would proudly and move to call the father of neurorehabilitation in India. And there would be no subsection without you, sir. And the path we walk so easily tonight, you walked first alone when there was no path at all. With all the love and all the respect this community can hold for you, sir, we welcome you, sir, Dr. Nirmal Surya.
Thank you, Gohan.
To our entire presidium, thank you for blessing this beginning with your presence. And to every young clinician watching tonight, look at who has come to stand with us. That alone tells you how much this work matters to us all. And before our leaders speak their blessing over this evening, allow me to share something with you. And I'll be honest, it has moved us as an organizing team far more than what we have expected. And we have received over 649 registrations. This was what we have received today morning, and we couldn't include the registrations after that. And for the inaugural sessions. And what's more important is that we have received registrations from 13 countries all across the globe, from United States, United Kingdom, Romania, Iraq, United Arab Emirates, Libya, Nigeria, Angola, Sri Lanka, India, Pakistan, Singapore, and Malaysia. And that's a very good representation from across the globe. And these are the various representations from the states. And over the course of Pathshala, as it expands, we would be looking to expand it further and further and take this teaching and knowledge from the experience and wisdom of our elders forward to the young learning generation and the clinicians, researchers, and therapists ahead. And this is a short introduction about our registrations today. And so with this extraordinary family that we have gathered together from across the world and under the grace and authority of the Presidium of the Indian Academy of Neurology, the NeuroRehab Pathshala is ready to be born today. And to launch this series and to give us their wisdom and their blessing, I now turn to the Presidium who leads us. First, to our President, Dr. Lakshmi Narasimhan Ranganathan, sir. I kindly ask you to speak to us and to declare the NeuroRehab Pathshala open, and this beginning belongs in the Presidium of the Indian Academy of Neurology, sir.
Thank you, Suguan. On behalf of the Indian Academy of Neurology, it's a proud privilege for me to inaugurate this Neuro Pathshala. The word Pathshala, running for thousands of years, as you've told, the knowledge is really shared here without any expectations. So I welcome all the delegates across the globe who have registered and be here part of this inaugural session of Neuro Pathshala. I welcome my colleagues, Professor UMS, Professor Nirmal Surya, and Professor Sudhir Kothari, the President-elect, my successor. I welcome the Neuro Subsection, the Secretary and the Convener and the Chairperson, Amakant and Dr. Abhishek. I invite all the delegates. I thank you once again on behalf of Indian Academy of Neurology for taking part in this Neuro Pathshala. I wishing this web series a grand success. My prayers to Almighty that all of you should enjoy this session. Thank you so much.
Thank you, sir. You have set us on our way, and I promise you that we will not let you down, sir. And next, our President-elect, Dr. Sudhir Kothari, sir, to launch the NeuroRehab Pathshala. A few words of wisdom, please, sir.
Thank you, Guhan. Thank you for inviting me for this extremely interesting new activity. I like the format that you all have made and how you all will have a very structured each time a talk, one case, and you will cover one of the various scales that are so important in neuro rehabilitation. And my only suggestion is just catalog it properly so that if anybody else wants to look up how to see a particular scale or a particular sort of topic, we should be able to find it easily. And I'm sure this is going to be the way you are launching it, the way I see the passion and the interest with so many registrations. This is going to be a huge success. So my best wishes for this, and I hope we'll you have not patented the name, because this Pathshala name is going to be adopted by many. People will try to adopt it. And it's a very nice name and very nice activity. My best wishes.
Thank you very much, sir, for the kind words of wisdom. And your faith in us means more than you can ever know, sir. And to our secretary, Dr. U. Meenakshi Sundaram, sir, who has been a strong pillar of support in this program, NeuroRehab Pathshala, we kindly request you to launch the program and say a few words of wisdom and encouragement, sir. Over to you, sir.
Thank you, Guhan. Good evening, everyone. Good evening to all these elite people who are on the panel. My president-elect, the NeuroRehab office bearers, the subsection office bearers, and my own friend, Dr. Nirmal Surya. Now, we have, I think, it keeps increasing. So I think the last count was about 23 subsections. And it's indeed very heartwarming when a subsection takes on a good activity, comes out with bright ideas, and tries to educate people. And Indian Academy of Neurology has always prided itself on being supportive of all such measures which can help the members, which can educate them, and especially if it helps the youngsters. So to that extent, wonderful job. And Pathshala, I remember that we had during a stroke conference a Gurukul. So this is Pathshala, and then Saleko Padhika Votum. So that's a Pathshala, and a path breaker. The path breaking guy is with you, Nirmal Surya. So I'm sure he will guide you to better and better heights. So best wishes. We look forward to learning from all of you. Thank you very much.
Thank you very much for all the support you have rendered to us, sir. Thank you, sir. With the blessings of the entire Presidium now upon it, the NeuroRehab Pathshala is well and truly alive and taking you through today. That's myself, Dr. Guhan, and our convener, Dr. Ramkant Yadav, sir. And next, we shall proceed to the introduction of the Pathshala course. And to tell us what this Pathshala truly is, what it is for, who it is for, and just how far it can carry the cause of neurorehabilitation in our country and beyond, there is only one voice that belongs here, the voice of the man who gave his life to building this field when almost no one else in this country and globe believed it could be built at all. With the respect of an entire generation that has learned at his feet, I invite our chairperson of NeuroRehab Pathshala, Dr. Nirmal Surya, sir, to introduce the Pathshala course before us. Over to you, sir.
Thank you very much, Guhan. I'm pretty sure that 200 plus people who have joined, they would have liked to keep on hearing to you, the kind of speech you have delivered and kind of words you have given for everyone. But let me tell you that neurorehabilitation is the need of our. And if Ashmita, you can share my slide. Unfortunately, I just landed from Dehradun, so my slides are not here with me. So Ashmita, please share. All right. So 2014, when we built the NeuroRehab subsection, and Dr. Tali and Dr. Anupam Gupta, that time the chair and convener, took the thing in the hand. Dr. Tali, all of you know that he was a man who really started the NeuroRehab thinking among the neurologists in India from Niemens. And I have to really catch the neurologist to become a member, which I could manage to get highest number of members in the NeuroRehab subsection. Over a period of time, persistent efforts by Abhishek and many other who joined the NeuroRehab subsection as leader made this possible, that we keep on introducing the need of NeuroRehab to neurologists. It has taken more than 10 years for neurologists to realize that how important neurorehabilitation is today. And when you really look at neurologists, and you ask, when I ask my resident, what is EDSS, what is FIM, can you describe me the mass scale, do you know what is Tardive scale? And none of them could tell on their own. And that is something which I felt that we need to have much more discussion and get the physio, OT, PMR into this team. So today what Guhan has started, I felt that once in a month, we should have a neuro rehabilitation sort of people to get a regular learning so that they don't forget, they learn. So when the teacher used to, Guan has already introduced you Pathshala. I'm not going to give you much more detail, but Pathshala means it is not a deliberated lecture. It means that you are involved, the student is involved, the teacher is involved, and there are like freedom to learn from each other. And that is what we are looking at. There can be questions, there can be answer. It will be once in a month because we want to have a learning which is consistent, regular, committed, and it goes throughout the year. We don't want to do 3 sessions, 4 sessions, and then forget for 1 year. We want it continuous. And we don't want it to be too long. So 90-minute focus, high-lead session, which is fit to schedule for a working clinician. We purposefully kept on Friday, and so that you can just mark it out that it is the third Friday and you have to mark it. And this will of course be all over the globe, and it will also be available to all IN member through the YouTube where they can connect. So it is going to be a continuous thing. The structure is very simple, 3 pillar. The one is learning lecture. So you have a 30 minutes where, I would also keep it even less than 30 minutes, give 20 minutes and 10 minutes for question answer so that you get a knowledge on that particular topic, which is a lecture. And then you have relevant case, which I would give a little bit more time so that case that can change how you see the next patient, what are the things you could have done in your patient and you have missed, and then clinical scale. So the scale, as Sudhir Bhai told, that they are very, very important, because today if you want to do research, today you want to write a paper, today you want to follow up a patient, the scale is what something which is tells you. And there are very, very simple scales which can be useful for you even in day-to-day practice, like sit to stand. And when you are talking of gait, many people not even doing 6-minute walk. So how many, or even how many steps in a minute. So these are very, very simple scales which can be used. And then we'll have 10 minutes of open question answer with faculty and panel. So teaching lecture, as I mentioned to you, which is a focus, high-yield clinical topic, will decide every month. And of course, what we are going to do is we'll give you next 2 months program after in next week, so that you know that this is what is next coming. So you are already, geared for that. Prepare your questions so that when you come, you can, even have your queries been immediately been addressed. Takeaway will be a way of approaching, assessing, and managing these patients in your own clinic. And not only that, I'm looking at that neurologists should be the stakeholder of their patient, and they should not be just thinking of leaving a patient after the acute illness is over. That means either stroke, encephalitis, or whatever is being treated, and they just say, go and do the physiotherapy. No, they should be the stakeholder. They should decide how the things are going to go in this patient and what best could have done. So they need to evaluate, manage, and then decide to weigh the clinical picture and later on follow it up consistently. The case discussion is what is next, and that case discussion will be on deficit based or on disease based. So you can have, with the next slide please. So we can have a case that we may take a case of say MS with presenting like that. Asmita, can I have next slide? Or we can take a case of say spasticity, which can be, discussed how we are going to manage spasticity in this patient. Or there can be a patient with the gait disorders, and then you have the real patient which is presented, which may be either defined by neurology deficit or by a disease. And then rehab decision, multidisciplinary plan, outcomes we'll discuss. And then, of course, again, you will be engaged. And this not only will be only one part, but it will be multidisciplinary. So there can be speech and swallowing, there can be OT being involved, or the cognitive case can be there. So, you get multiple choice. And the cases are chosen to build the clinical instinct that everyday practice demands. So you will have a takeaway confidence in managing similar patient in your own practice. Then you have clinical scales. Next, please. So clinical scale is something you need to demonstrate, and each session demonstrate one clinical scale, how to administer it, how to interpret the score, what a change in the score actually means clinically, and how to apply it in everyday work. Where the scale needs more than allotted 20 minutes, accompanying reading materials are shared to extend the coverage so that attendee can master the scale in full. Again, takeaway will be a usable measure tool added to your toolkit each and every month. So what you do now, there will be a quiz, monthly quiz. So, you can't just get away that you will attend the lecture intermittently, or, we would want a competition. Next slide, please. And we would want to know that how well you have understood. So you'll have after every session, there will be 3 questions, 1 minute each, from the lecture, from the case, and from the score. And then you will have the top scorer across all the session will be accumulated. So, if you are really interested, end of a year, those which are winner, I'm sure the president, secretary, president-elect, they would like to felicitate them during our annual conference and give them a trophy and a certificate, whichever, or the cash prize, whatever IN decide, would make it more interesting that you are not only listening and involving, but you are also fighting for your, command, or for your top scorer, or for your quiz winner. So that is something you are in a competition. So you are not going to just finishing that. So next, so beyond the 90 minutes, what we are going to give, the learning will continue. Next slide, please. And we will have the reading material, we'll have monthly quiz and year-end score summary. So, don't think that this is going to end today's lecture. It is going to be continue, and we want to plan new things. The neurologist has to get more and more active, learning about NeuroRehab, knowing that new things are coming. And I would urge all the neurologists who are practicing in the hospital, private clinics, should understand the rehab and have their rehab setup, so that things like injecting the botulinum toxin for spasticity, things like FES or the RTMS in long term, or TCDS, all that can be used. And it is more important thing is when to use, which patient to use, where to use. And these are the things which we are going to discuss and come back to you. So with that note, the format I have already shown you. We have discussed about it. So fourth Friday, every month, 7 to 8:30, and it is via Zoom for all of you. So today is the inaugural. Next will be 24th July, 21st August, 4th September, 27th November, 18th December. You might find that some changes in the date. That is only because of either there is a festival or there is some important national meeting where IN is participating. So we have changed that. So I welcome you all, the clinicians, the rehab professionals, researcher, the therapist, the resident, the student, PhD student, and MSc student, everybody. Pathshala is open tonight. It is up to you. You want to learn, you want to discuss, you want to measure, or you just want to listen and sleep. You decide. And those who are eager and those who want to do something, let them participate in the quiz. We will love to have the winner, not one, but more than one from all of you. Over to you, Guhan. I wish you all the best, and I hope that uh, the feedback from those who are attending will make us more strong for the teaching and training in the future. So please keep on giving the feedback and keep on. If you also want to participate, want to send a case and want that case can be discussed, please send to Guhan and we will decide among all the cases which case can be discussed, can be useful for everyone. And those whose case will be accepted again, we will like to felicitate them and have them recognized. So Guhan, please make a note of that, that if any of those who are attending sends a case to you, you select the case, we discuss, and anybody's case selected, we should honor them. Over to you. Thank you very much, and I wish all the best. And thank you, Dr. Lakshmi, Dr. Sudhir Kothari, and Professor UMS to be here and give a support to the neurorehabilitation, which has grown in leaps and bounds in past 1 decade. Namaskar. Thank you.
Thank you very much, sir, for the ever-inspiring words that you always instill in us, sir. And now that our lamp is lit, our elders have blessed us, and now we come to the real reason where we all have gathered here. That's for the Pathshala. So let us begin and think for just a moment of the most ordinary miracle there is. That's a person standing, a person taking a step. We never once notice it until a stroke tears it away in a single merciless moment. And from that moment, there is nothing on the earth a family wants more than to watch their loved one walk back through our front door. And exactly that is the work of our speaker to teach us how to assess and rebuild the act of walking itself after a stroke completely and beautifully. And we are honored to welcome the master himself of neurorehabilitation, Dr. Abhishek Srivastava, sir, who's the most respected voices in physical medicine and rehabilitation in this country. And please join me in welcoming Dr. Abhishek Srivastava, sir, the Director of Center for Physical Medicine and Rehabilitation at Kokilaben Dhirubhai Ambani Hospital, Mumbai, to talk on comprehensive neurorehabilitation, evaluation, and management of post-stroke gait in stroke. Over to you, sir. Our floor and our complete attention is yours, sir.
Thank you, Guhan, and thank you, elders, for the kind introduction. It's a brilliant initiative. So I will not do justice if I don't speak about comprehensive neurorehab to begin with. So just to the slide visible?
Yes, sir, it's visible, sir.
No, it's not moving forward. Yeah. So what happens to a patient who had a massive stroke or a brain injury? We have scans like this, a bad hemorrhagic stroke, a bad ICA, stenosis, a bad brain injury, bad decompensationectomy. How do you think they are at 1 year post-stroke injury, lying at home or in ICU or vegetative state? No. If they get comprehensive neuro rehab, they can become better. So my first job is to these myths. There are some myths among all of us who are doing our training. The myths are patients with either brain injury and stroke should be discharged home when they're off ventilator. They don't recover after 3 months. Inpatient rehab has no advantage over home-based care. Here, robotics have no advantage. Neuroplasticity plateau very early, and patients need rest after stroke or brain injury. We all have been brought up with these myths. Remember, these myths are wrong, and all of us who are part of neurology NeuroRehab should ensure that our patient should not follow this path. So, what does NeuroRehab do? Patients with stroke or brain injury or PD or MS or whatever have multiple impairments. The impairment top to bottom can be cognition, behavior, vision, speech, language, swallow, sensory loss, tone abnormalities, motor problems, bladder bowel incontinence. So our job is to identify all these impairments and treat them. If you don't do that, people will have
Sorry
disability.
to disturb Abhishek, sir. There are a few messages saying the voice is low, sir.
Okay. So if you don't treat these impairments, people can have disability, which can be in mobility domain, self-care domain, cognition domain, communication of bladder. So what does NeuroRehab mean? Can we change the brain? When we are studying medicine, you're told we cannot change the brain, which means brain deficits remain for life. And if ask somebody what a NeuroRehab means, 9 by 10 will say therapy, therapy, and therapy. So what has changed? Multiple things have come up in the last 10, 20 years. Neuroplasticity concept, impairment-based approach, continuity of care, goal planning, team approach, oxygen therapy, music therapy, decongestion protocols, newer technologies, robotics, pharmacotherapy, tone management, neuromodulation. These things have completely changed the outcome of our patients under neuro rehab. Just to summarize few basic things, take example of stroke. What happens in first few days? We all know there's a penumbra. We can burst the clot. We can do clot retrieval. We all know that. But can we start some drugs very early which improve motor and language function? Yes, it's possible now. And what happens in first few months is what happened primarily in rehab. Brain recruit additional area to perform new function, or other part of brain takes over function. This ability of brain to change and respond to a stimulus is neuroplasticity. What are doing in rehab is to get the plasticity by two ways: by intensive training, different therapies, using technologies, or have a newer treatments like pharmacotherapy and neuromodulation. Always remember, rehab starts in the ICU, rehab continues, and what's most important, especially, is the formation of these stroke units, followed by acute inpatient rehab units. So patients who are neurologically stable, out of ventilator, but have disorders of consciousness, multiple impairments, should be managed in an inpatient rehab unit. When the tubes are out, they are conscious, they can be shifted to a daycare program, an outpatient program, or home program as per the facilities available. And a whole team is required: neurologists, neurosurgeons, rehab physicians, physical therapists, nurses, occupational therapists, speech pathologists, psychologists, social workers, all are required because there are 10 to 12 impairments, and none of us can do all these things together. And always remember, the intervention in your rehab can be of 5 basic things. These patients still have medical needs. They do provide continuity of medical care. Second, you have to prevent, treat secondary complications. The patient can undergo therapy, and then give them training for sensory motor deficits, training for cognitive, communicative, and sorrow deficit, and prevent and treat psychological and social issues. So a NeuroRehab prescription of after admission is quite exhaustive. It includes pharmacotherapy, chemodenervation, chemoneuralysis, corrective casting, corrective surgeries, nerve blocks, speech language therapy, swallow therapy, all type of physical therapy, orthosis, OTs, social work, and so on. And if you do that, we call this 666 concept. These patients should get intensive therapy in first 6 months to maximize their potential to recover. And if you see those same slides, same scans again, all these patients actually went home walking from the hospital. So patients who have massive stroke or brain injuries, if they get comprehensive care, supervised programs, they can do well. And it's a myth that they can't improve. People can change. What they need is good care. With this introduction, to today's topic. Today's topic is post-stroke gait disorder. So what is gait? Gait is a human walking locomotion which starts from one initial contact to the opposite initial contact. It has two phases: a stance phase when foot is on the ground, a swing phase when foot is off the ground. The stance phase is 60%, swing phase is 40%. Stance phase itself have specific events: initial contact when the foot touch the ground. Second, loading response, the knee slightly bends to take the load. The mid stance when knee is in extension and the opposite limb goes into swing phase. The terminal stance when there's a good hip extension of the stance limb. The pre-swing phase when the heel is off. The swing phase has three events: the initial swing, when the toe is also off and knee starts to bend, a mid swing when the foot crosses forwards, the opposite of the mid stance, and third, the terminal swing phase to prepare for the initial contact. If you see, so in most of the stance phase, the hip extends. The hip extends in most of the stance phase. And rapid ankle plantar flexion at the end of the stance phase propels the body forward, and the knee, it remains in extension most of the stance phase. This concept is called as inverted pendulum. If you see in the beginning, the hip goes into extension, that's a burst of activity. In the end, ankle goes into plantar flexion, burst of activity. Whatever happens in between, it is just using the body reaction for ground reaction force. There is no active muscle contraction in the both of stance phase. Initial part, glute max, and gastrocnemius and soleus in between. It just the body reaction forces maintain the limb into stance position. In the swing phase, initial contact, you have the heel of the toe off to next heel strike. In this phase, the foot moves forward in front of the hip. And to propel the body forward in this stage, the hip has to flex, the knee has to flex, ankle has to dorsiflex so that body can propel forward. So always remember, we can ourselves analyze this simple gait with our phone camera. You can make a person walk and you stand on the other side. It's called a sagittal plane. Take a video when a person is walking from the sides. This is the same thing we are seeing. This is called as video gait analysis, which we can do with the phone camera. Take a video, and then this is your stand initial contact when hip is at 30 degrees of flexion. In the whole stance phase, hip will extend. Then hip will start flexing in the swing phase to the mid swing. Again, it starts coming down to the hip flexion. What you to observe are these two key events. How is the hip at pre-swing phase, at the mid-swing phase? Just mark it. Mark it on one phone, you can do that. Play it slow motion, mark these events. Like for knee, when we put a foot on the ground, knee is into the neutral position, then knee goes into a initial loading response in mild flexion, the knee extends again back to the mid stance, and the knee plexes fully 60 degrees into the mid stance, again comes back to neutral in the next initial contact. What look for these three key points: how the knee at initial contact, how the knee at mid stance, how the knee at mid swing phase. Third is ankle. If you see the ankle graphs here, ankle initial contact is a neutral. It comes to mild plantar flexion, the loading response, and then goes back to the ankle dorsiflexion in the mid stance. It again plantar flexes in the pre-swing phase and goes through dorsiflexion in the mid-swing phase. Again, look for ankle at initial contact, at mid stance, at pre-swing, or at mid-swing phase. This is called as 2, 3, 4 hip knee ankle concept. We all can do it with our simple phone video cameras. Mark these key points. If you take it further, this is called as kinematics, movement happening in plane. What cause these movements are the movements and the muscle contractions. A simple slide to show. Again, initial contact, the hip is normally in 30 degrees of flexion. Then what happened? As we know, in the whole stance phase, the hip extends. What makes it happen? In the initial stance phase, the gluteus maximus, erector magnus, and the hamstring, they all contract concentrically which means muscle is shortened and the hip extends slowly to the neutral. And then at the pre-swing phase, a little longer starts contracting, and then the hamstrings contract concentrically so that the hip flexes in the swing phase. And in the terminal swing, the hamstring contract called eccentric contraction, they lengthen to smoothen the movement so we can do a 30 degrees of hip flexion again. Same way, knee in the beginning is neutral initial contact, which is because of co-contraction of quads and hams to keep it at neutral. And then the eccentric quadriceps contraction to smoothen the shock effect. And then in the whole mid-stance phase, the gastrocnemius contract eccentrically. And then for the swing phase, the hamstring contract again concentrically to shorten the knee. And in the end, both hams and quads lengthen to smoothen the knee back to neutral position. Same way in the ankle, initial contact is neutral position. Then there's a mild plantar flexion. The tibialis anterior does eccentric contraction. Then gastroc comes in, and then again the peak gastroc concentric contraction at the pre-swing phase, and then the tibialis anterior takes the ankle back to neutral to the mid-swing phase, and in the mid-terminal swing, tib and contract isometrically to maintain it in neutral position. That is how muscles work in both phases, concentric contraction, eccentric contraction. So stance phase is primarily rapid hip extension and ankle plantar flexion. Rest all what happens here is all are eccentric contractions in the whole the mid stance phase. And in the swing phase, it's all concentric contractions in the beginning to flex the hip, knee, and ankle. And then in the terminal swing, all muscles again have eccentric contraction to prepare the foot land on the ground again. That's how the beauty of the contraction of muscles to harmonize our gait pattern. So what happens in stroke? In stance phase, four things happen. They decreased peak hip extension in the late stance phase. Hip doesn't extend fully in the pre-stance phase. There's a increase or decrease knee extension in the early or mid stance, or they decrease ankle plantar flexion at toe off. This mainly happens because of you can't appropriately activate the muscles because of weakness, or there is muscle shortening because of spasticity. If you go into detail further, there are multiple reasons. So first deviation is decreased peak hip extension in late stance phase, which means hip is not extending the late stance phase. The common reasons are if there is hip extensor weakness, or there is hip flexor tightness, or there is ankle plantar flexor tightness to maintain the hip and knee into flexion, or the knee remains into flexion. Now, in the stance phase, knee can be goes into hyperextension, which is mainly because of quadriceps spasticity or hamstring weakness, or ankle remains in plantar flexion. So not it will go in front of the knee joint, push it backward. This is the most common abnormality you see in people with stroke. Or there can be increased knee flexion in mid stance, which is mainly because of weak quadriceps or knee flexor spasticity. Same way, ankle might be decreased ankle plantar flexion at toe off. That is mainly because of weak ankle plantar flexors at this stage. Same way, in swing phase, we can have a decreased peak hip flexion, decreased peak knee flexion, decreased knee extension prior to initial contact, or decreased ankle dorsiflexion throughout swing phase. People have foot flapping, is very commonly seen. Again, the common reasons are inappropriate activation because of muscle weakness or out of phase work, or shortening of the specific muscle groups because of spasticity. So remember, the weakness, the spasticity, and the gait compensation to both of them ultimately divide what gait pattern you have. So a decreased peak hip flexion is mainly because of hip flexor weakness, or reduced hip extension in the stance phase to give less excursion. Same way, in swing phase, you can have reduced knee flexion in the early swing phase, mainly because of hamstring weakness, quadriceps spasticity, or ankle plantar flexor spasticity. You can have decreased knee extension prior to heel strike because of hamstring spasticity or weak quadriceps, And same way in the swing phase, you can have reduced ankle dorsiflexion, which is very commonly seen in most of stroke patients because of ankle dorsiflexor weakness or ankle plantar flexion spasticity. So remember, every event can happen because of both reasons, the main muscle being weaker or the opposite muscle being stiff or spastic. So to summarize this thing, we have these four gait patterns in patients with post-stroke hemiplegia. This is taken actually from cerebral palsy literature, but it is true for any UMN type of lesion. So the first type of pattern is when ankle remains in plantar flexion, but there is no contracture. So there is just a foot drop in the swing phase, like a LMN foot drop, common period nerve palsy type of picture happened in the early stroke in the first few weeks. And at that time, there is just foot drop in the swing phase, no ankle plantar flexion spasticity. These patients just require therapy as an AFO, nothing else. Type 2 gait pattern is true equinus with neutral knee, where people have tight ankle plantar flexion because of spasticity, with knee remains in neutral. Treatment primarily is give them chemoderivation with botulinum toxin, neolysis with phenol block, give them an AFO, and start therapy. Type 2B, when there is a knee in recurvatum, very difficult to treat. This is further augmented by weak hamstrings and tight quadriceps, along with ankle problems. Type 3 is true equinus with a jumping gait pattern, and ankle is in plantar flexion, but knee also starts to flex because of hamstring spasticity. And type 4, these patients will require a knee brace also along with plus medication and botulinum toxin. And type 4, when ankle is in plantar flexion, hip is in, knee is in flexion, but hip also starts to flex with internal rotation. This mainly because of addition of tightness of either hip flexors like iliopsoas or rectus femoris or TFL or pectineus. So you have to identify the gait pattern, make a person walk, settle plane, take a video, identify the pattern. Treatment is very simple accordingly after that. How can you change this pattern? How can you treat this? There are 4 or 5 basic things. First is physical therapy, which has basic concept of Bobath approach, a PNF approach, a Boomstrom approach, autodendral program. You have to stretch the spastic muscle, strengthen the weaker muscle, start weight bearing training, do proprioceptive training, do endurance training, learn to make them walk. What is a big game changer in stroke is an ankle foot orthosis or an AFO. Cochrane review says that it helps significantly to improve the walking speed, improve step or stride length and their balance distribution. Old older days AFO, then leaf spring AFO, then solid ankle AFO, articulated AFO. Now we have carbon graphite AFOs also. Pharmacotherapy, yes, there is some role of escitalopram in improving motor function in stroke patients now, which is the EN approval for 20 mg escitalopram for motor recovery. Rest all trials have failed. Most important is tone management, which means treat spasticity, dystonia, or rigidity, whatever the patient is having with lesion of the stroke. You can do splinting, stretching. If it is generalized, start oral medications. We know baclofen, tizanidine, clonazepam, tolperisone. Regional spasticity, very severe patient might have baclofen, but very common is focal multifocal spasticity. These patients will require botulinum toxin or phenol injections. And now the evidence to show that use some guidance, either ultrasound, EMG, or E-stim to plan your injections. Level what evidence available now. It is much more cost effective, lesser dose, and better for your patients. And then the mainstay is different type of technology which has come up now. So we have supported by dynamic supported training, by body weight support, dynamic posturography, FES, neurofeedback, mental practice, mirror therapy, virtual reality, robotics, neuromodulation. A lot of things have come in last 10, 15 years, which help to improve these gait patterns further. Take some case examples. This lady is 20-year-old girl, 3 months, post-retinal infarction. She referred to us for botulinum toxins about 10, 12 years back. If you see the way she is walking, she's first touching her toes, not the heel. The knee goes into hyperextension. It's like type 1 or type 2 gait pattern. When you clinically do an evaluation, the voluntary control and hip flexors 2 to 3, knee extensors were 1, knee flexors were 1, quads were 2, ankle DF were 0, ankle PF had some power. They're very mild spasticity in ankle plantar flexors, gait 1 plus. Silver rate was positive. We'll talk about it. And if you see a gait analysis report, we had a lab, this 3D analysis report. These are temporal parameters. These are normative values. Green is right side, red is left side. She right hemiparesis. You can see the normal values here. She has an increased stance phase duration, increased double support time, increased stance phase percentage duration, increased stride time. The cadence is reduced, the normative values. Step length is less, step velocity is less, swing velocity is less, step width is more. Very inefficient gait pattern. What to do? If you see the kinematics, this is a lab showing it here. This is the ankle, same graph. You see this normative band is the blue, gray one, green is the right involved limb. The ankle is in plantar flexion, the initial contact. There's some DF happening in the mid stance, but very less ankle DF in the swing phase. Typical, she's slapping. See the knee, it not flexing fully into the swing phase, it not extending fully into the pre-swing phase, the anterior pelvic tilt. So what to do? Physical therapy for strengthening, balance training, proprioceptive training, gait training, endurance training, give her a AFO, do FES to quadriceps, a short course of training on robotic assistance. This is how she was at 6 weeks. She's walking faster, she's bending her knee, she's flexing her hip. And if you see the difference in the pre and post rehab 6 weeks difference, the stance phase percentage has improved, double support time has improved, stance phase duration is reduced, swing phase duration is reduced, stride time is better, nearly equal now, cadence has improved to nearly normal, the step length improved, swing velocity improved, step width reduced, knee velocity also improved. And if you see the pre and post kinematics, the ankle is still the same here because this is pre, this is post. If you're walking with the AFO, this test was done without the AFO. But if you see here, difference is knee is now flexing fully in the mid swing. The hip, which was less, is now extending fully in the pre-swing phase. Just by good therapy, FES, and short training robotics, she learned to walk in a much more normal gait pattern. Another case, he came for first follow-up post his bleed, was able to walk with a stick, like a tripod cane. She told doc, can I remove my stick? Is it possible? Let's see. His voluntary control was again ankle plantar was 3, ankle DF for 2, quads were 4, hams for 3, spasticity ankle plantar flexors on modified Ashworth grade 2, knee extensors were also grade 2 spastic, even hams were also spastic. A positive Silva test, negative Thomas test, negative Rectus test, orbital angle. What these tests are? Good orthopedics days, Thomas test is to check for hip flexor tightness. Check with the right side, flex the opposite hip completely. Orbital lumbar losses, whatever angle is formed here is the hip flexion contraction. If this is positive, means tight hip flexors, which can be iliopsoas or which can be rectus femoris. Both can do that. To differentiate that, make a person prone. When he is lying prone, if the pelvis ASIS is touching, there is no flexion contracture. If it's already up, meaning iliopsoas is tight. Then if you flex the knee, you are stretching the rectus femoris. If this angle increases, it means culprit is also tight rectus femoris. This is called as Duncan-Ellis test. So your hip flexor tight can be both because of iliopsoas, rectus femoris. Same with knee, it's called a popliteal angle because of the hamstrings. Make a person lie down, give a full stretch, and then you see how many people it is producing here. This is the most important test called a Silva scale test. Remember, ankle plantar flexors are two different muscles. The gastrocnemius, which starts above the knee joint, and soleus starts below the knee joint. We're checking the ankle plantar flexor angle or tightness with knee and extension, both the muscles are acting. When you flex the knee and check it again, you get the full correction like here. It means the main tight muscle is only gastrocnemius, not soleus. If you don't get full correction, it means both are tight. So depending upon theoretical test positive, if it's positive, you only inject gastrocnemius. If it's both, you inject gastrocnemius and soleus, both the muscles. Same person, if you go back again. If you see here, he is not extending his hip fully, not flexing his hip fully in the mid swing phase. His knee is in persistent extension, not flexing fully. If you see his ankle, he's landing on his toes, not doing good DF in the mid swing phase. If you have a lab, you can do the same things here. The ankle is in equinus initial contact, not DF in the swing phase. Knee, you can see it in extension initial contact, not flexing at all in the swing phase. Hip, again in mild flexion in the initial contact, not extending fully. But it means if you do the problem list, what problem we saw in this initial slide, he has all these problems, which means there is increased ankle plantar flexion, knee extension coupled in the stance phase with reduced hip and knee flexion and ankle DF in swing phase. This is amenable to interventions, botulinum toxin, pharmacotherapy, chemodenervation, chemoneuralysis. This swing phase issues is more of strengthening primarily. So we did botulinum toxin, 200 units, 133 in gastrocnemius, 6 in rectus femoris, lung baclofen for the physical therapy. And this is at 4 weeks. The stick has gone. He can bend his knee, he can bend his hip, he's landing on his toes. And if you have a lab, you can see one thing is good. The ankle is now, you can see the red one. Ankle is neutral, good DF, knee no flexing, good. But what's wrong? That knee is in mild flexion now in the initial contact because he also had hamstring spasticity, which we have not treated. This patient was required botulinum toxin in hamstrings also at the same time. You see pre and post, ankle which was in equinus is neutral now, initial contact is a red line. It also dorsiflexing fully into the mid stands. Knee flexion is improved. Only issue is the persistent knee flexion contact which requires hamstring injection also. Another case, this last case, summary read up. This guy came at 4 months post ICH, required support to walk. And if you see here, he's landing on his forefoot and on the lateral border, good equinovirus, which you see in most of your stroke patients. Again, do a silver skewer test always, check it, and then do a voluntary examination, do spasticity checking, do all these special tests. He had positive tardio and mass both for ankle PF and inverters. Knee was 4, ankle plantar effects were 3, weak DF, hamstrings were 2, tight 3, grade 3, mass spasticity in gastroc and tibialis posterior, no soleus required. We did now we do something called as goal setting. These patients have multiple problems. One is we have to reduce ankle plantar flexor spasticity, reduce ankle inverter spasticity, reduce ankle foot pain, do fitment for AFO properly, improve knee flexion and swing, improve dynamic balance, better get with AFO. We have all these goals to manage him. We did botulinum toxin for his gastritis and tibialis posterior. With some guidance, you can pick up the gastroc here, inject this straight away here, and then see tibialis posterior deep inside both the bone close to the gutter muscle. And then post-procedure care is very, very important. You have to stretch the injected muscles, strengthen the opposite muscles, training on proprioception and weight bearing, remold the AFO, train him to walk with the AFO with a cane. He came at 1 month post-procedure. Now, if you see, his inversion is gone, but still landing on his toes. Why? Because he's not using his AFO. So if you like something called as can do a gas scale, which is goal determinant scale, same goals. If you achieve that goal, it's 0. If it's even better, is 1 plus. Even better is 2 plus. Don't achieve it, it's -1. It's worse, it's -2. So ankle PF spasticity was yes, we had 0, able to achieve gas 0. Inverter has completely resolved, gas 1. Foot pain was better. AFO mold was taken. Some knee flexion swing was happening. balance was better, but he was not using his AFO. That's why walking didn't improve the level we thought he can change. So just to summarize, people with hemiplegia, when they walk post-stroke, the requirement of energy is up to two-thirds high than a person without a stroke. And use of AFO has a lot of benefits. One single intervention, training, spasticity management, and AFO can change life people with stroke for their walking ability specifically. Just to summarize, always remember, conventional rehab was primarily a disability management concept, which means if you can't walk, give a stick and just let them go home and do therapy. What it caused, it further caused learned non-use, which means we never focus on their ability, we only focus on their disability. The one is we lost the impairment evaluation and reduction and give them further learned non-use. What we require now is an impairment-based approach for cognition, behavior, speech, language, swallow, movement, tone, bladder, bowel, all treat all the impairment. If you do that, it prevent a disability to happen. Thank you very much.
Thank you very much for the wonderful lecture, sir. And especially for the neurologist out there listening to this lecture after my neurology residency, when I attended my first fellowship in neurorehabilitation, and my HOD asked me to comment on a gait of a stroke patient. I said, circumduction gait. What's there more in it? And that's when I started to realize that it's not just circumduction. What happens at the hip, what happens at the knee, what happens at the ankle, which is overacting, which is not overacting. At first, it was very overwhelming for me, looking into all the kinematics, and the physics is one that I hated, and that's why we took medicine. But physics chases you all along. These reading material will be shared with you. Go over it again and again and again until you master it, because the first thing that we want the patient to do is walk back again. And for that, we need to know the gait angle by angle, kinematics by kinematics. And thank you very much for the wonderful talk that summarizes everything, sir. And if there are any questions, please post that in the chat box, and then we will be taking up with the questions with the experts. Moving on to the next talk, that's a case presentation. And there is no textbook in the world that's wiser than a single patient. And so we move from the foundations to the living, breathing heart of our craft. That's discussion. And it is my pleasure to welcome Dr. M. Arun Shivaraman, who is a consultant neurologist and a NeuroRehab styled neurologist at NG Hospital and Research Center, Coimbatore. And he's very young, dynamic, energetic, that you would be seeing in his case presentation and discussion on rehabilitation of a patient with Parkinson's disease. Dr. Shivaraman, over to you. Dr. Arun Shivaraman, your mic is muted and your video is off.
Sorry.
If there are any questions, please post it in the chat box.
Am my screen visible?
Yes, Dr. Arun.
Good evening, everyone. At the outset, I would like to thank my mentor first, because without his guidance, I would not be able to be speaking in this session or wherever I am. And I also like to thank IA NeuroRehab Subsection for this wonderful opportunity to interact with you all. So I'm Dr. Arun Shivaraman. We are going to see a specific case of Parkinson's disease, how neurorehabilitation and neuromodulation helps in treating a patient and making the patient's life and their caregiver's life more easy. So, starting with the case history, a 64-year-old male diagnosed with Parkinson's around 6 years back. His chief complaints were progressive gait difficulty with recurrent falls, freezing of gait on initiation, turning, narrow spaces and doorways. He is having hypophonia and dysphagia with aspiration. He has a comorbid coronary artery disease with systemic hypertension. And these are the drug list. with levodopa equivalent dosage of 610 milligram per day, and he was on other drugs for his cardiac pathology as well. So our impression was it is an advanced idiopathic Parkinsonism with the history, more of an akinetic, rigid, and progressive postural instability with gait disability phenotype, predominant axial and bulbar involvement. I am pertaining the examination to Parkinson's. A patient was having hypomania, hypophonia, cognition was impaired, tremors were absent, rigidity was more in the axial more than appendicular. It was cogwheel rigidity, not a lead pipe one. He was having bradykinesia. He was having the gait was short stepped, wide based, festinant, and patient freezes on turns and pivot on turns. His postural reflexes were impaired and pull test was positive. So to summarize, he is having gait failure, it is start hesitation, festination, freezing on turns at doorways and worse during dual tasking, recurrent falls and turning, bulbar patient was at aspiration risk. He was also having non-motor manifestations as well. So the medicine had done what the medicines can do with the levodopa dose of 16 milligram per day. Could intensive rehab with brain stimulation, that is neuromodulation, give back the function they no longer could. And I would like to also to mention that the patient's dopaminergic drug dosage was unchanged throughout the whole rehab process. So this was the initial gait of the patient. Can you see patient was needing support to walk, was having short steps, he was having severe postural instability, and he pivots on turn. He was able to walk only with the help of our therapist. And he also had recurrent injuries in the toes due to walking. Turning was difficult. This was the initial video. So what did we do? As Nirmal Surya sir promptly mentioned during the introduction, the scales are very important so that we can objectify the patient's improvement and we can reproduce the results to the caregivers and attenders with what we have done, what has been improved. The first we did was time tuck test, that is timed up and go test, that measures the basic functional mobility. We should ask the patient to sit in a chair, to stand, walk for 3 meters, return, and then sit. It strongly predicts falls and ambulation in PD. The normal value is less than 10 seconds. If the value is more than 20, patient is of high fall risk. Our patient was around 27 seconds. The next test we did was mini best test, that is balanced evaluation system test. It is a 14-item balance test course across anticipatory control, reactive postural control, sensory orientation, and dynamic gait. It hardly takes 10 to 15 minutes to apply. It is validated specifically for PD and outperforms Berg balance scale in identifying fall risk in Parkinson's population. The scores of less than 20 is means patient is of high fall risk. Our patient had 10 of the total of 28 scores, 28 score. The next scale we did was freezing of gait questionnaire. It is a 6-item patient carer questionnaire for freezing of gait for duration, frequency, triggers, and functional impact. The items cover gait initiation, turning, walking in the narrow spaces, duration, and overall walking difficulty. It is validated for PD. The overall score is 24. If it is less than 8, it is considered as mild. If it is more than 17, it is considered as severe, and our patient scored 17. The next to assess is eating and the risk of dysphagia. There is an eating assessment tool 10 kit. It is a 10-item self-report swallowing symptom scale with a maximum score of 40. The cutoff of more than 3 indicates a higher risk of dysphagia, warranting further assessment. Our patient score was 20, which means he had a high risk for dysphagia too with aspiration. And voice handicap test, which assesses the hypophonia of the patient. With the total score of 20, more than 3 suggests the patient is having voice problems, and the more higher, the greater the perceived handicap. Our patient's voice handicap index score was 24, and our assessment is not complete without MDS UPDR scale and HNI staging. Our patient was at HNI 4, and I don't want to go in deep into the UPDRs because everyone knows about it. Our patient part 1 score was 41 of 52 and part 3 was 43 of 132. So to summarize, patient stage at HNI 4, which interprets into advanced functional disability. The tuck test was 27 seconds, which means patient is at a high risk of fall threshold. Freezing score FOC sheet was 17 of 24, with a severe freezing of gait. And mini best test to assess balance showed high fall risk. E10 kit for swallowing showed marked dysphagia and aspiration risk. And voice health index test showed patient has severe voice handicap, and UPDRS shows severe achyconic rigid motor pattern. So before going into proper rehabilitation, what is RTMS? As Guhan usually mentions in all the talks, it is a magic wand in our hand. We consider RTMS as the primer and the physiotherapy as the driver. So TMS raises the cortical excitability, induces the long-term potentiation like plasticity and permissive state. In this case, it releases striatal dopamine. And physiotherapy, the driver, the intensive deficit-specific task practice improves the durability of the motor training. So we are trying in the patient and then training the patient. The TMS opens the plasticity window, and physiotherapy delivered in that window is consolidated more efficiently than either alone. So how RTMS helps in Parkinsonism? We all know the direct pathway of from basal ganglia. The motor cortex releases glutamate, which activates striatum, which inhibits the GPA, which is the gatekeeper, and finally it activates the motor cortex. What happens in Parkinsonism is, in striatum, the dopamine is depleted, so reduced inhibition to GPA, globus pallidus internus. The gatekeeper is overactive, which results in underdriving the thalamus, which further fails to stimulate the motor cortex, which results, for example, say slow and frozen gait. So RTMS reconditions the circuit. High frequency stimulation at SMA increases the cortical excitability, which increases the corticostriatal glutamate release and striatal dopaminergic release, which inhibits the GPA and improving the thalamus output to the motor cortex. So RTMS conditions the circuit and physiotherapy rewires it. So what is the protocol that we give in patients with Parkinson's, particularly in gait disturbance? The target is supplementary motor area. Bilateral midline is on 3 centimeter anterior to the ZZ. And rationale, frequency, we give high frequency excitatory protocol with 90% of resting motor threshold, with the pulse of around 1500 to 2000 pulses per session. The timing is we deliver immediately as soon as before physiotherapy. The coil used is figure of 8 coil, and the treatment schedule is we give the induction phase of 5 days a week for 2 weeks, and alternate days, 3 days a week for the third week, and twice weekly for 4 and 5, and weekly once for 6 weeks, and then monthly ones going on. So this is our patient getting the RTMS session. The figure of 8 coil is in the midline. I just want to see where the pulse delivered, so I'm just waiting. You can see you can hear the sound, the pulse is delivered. This is the stimulatory protocol that is being administered for a patient. So what is the physiotherapy program that we followed in our center for this particular patient? We targeted the sensory cue and improved the awareness, task specific and dual task training, balance and fall prevention, and home physiotherapy. Phase 1 was a foundation phase, that is the sensory cueing and awareness phase. The techniques were rhythmic auditory stimulation, visual floor cueing, verbal self-cueing, and freezing of gait trigger mapping. So rhythmic auditory stimulation is nothing but metronome beats, which should be set 10 to 15% above the comfortable cadence of the patient. So there is an app called Metronome in Android for free. You can download it. You can have that metronome beats in your phone. It entrains the step timing via the auditory motor network, bypasses the internal rhythm generation of the basal ganglia. Then visual fluid is just keep applying the adhesive tapes at half a meter intervals, and patient is asked to step with the heel first rather than the toe first. The visual cues recruit the dorsal cortical pathway and substitutes the basal ganglia automaticity. Verbal self-cueing. Patient is instructed to speak and then walk. Big step. I want to have a big step. Heel first. And it activates the supplementary motor cortex via the internal speech, further increasing the cortical motor drive. And for trigger mapping is done by systematic documentation of patient-specific triggers. For example, our patient had difficulty in turning, as you already see, doorways and in hurried situation. Then comes the dual task training. The first thing was tri-link biofeedback. As we already seen with the visual floor markers, we started with half a meter and then we gradually increase the distance to 10% per week. And then patient is asked to walk on the ramp and outdoors. And backward walking training, a 10-minute per session, it progressed from parallel bars to free walking. And dual motor tasks like walk and carry a tray, or stepping over a hurdle or an obstacle. And motor cognitive tasks, patient is asked to walk with subtracting serial sevens or adding serial sevens, word fluency testing, or otherwise using a mobile phone. Coming to balance, we did anticipatory postural control with sit to stand exercises and rise to toes, single leg stance, step up with arm reach, wide to narrow base, and reactive postural control with perturbation based exercises by the therapist, sensory orientation with foam standing, incline board, and head turns while standing, and dynamic gait training with gait with head turns, change in speed, step over an obstacle, and it all should be followed with strength training of the core and the lower limbs, which supports all the other systems that we have already seen. And for voice rehabilitation, LSVT loud was done. There are 4 components to LSVT loud. There is maximum sustained phonation. Patient is advised to sustain for the maximum loudness as long as possible. And high effort functional phrases. Patient is asked to read aloud with high effort and loudness recalibration. They say that is the basis of LSVT loud and LSVT big. They say that patient's brain trains to think that hypophonia is the normal movement that is there. So patient brain should be retrained to make larger amplitude movements and loud voices. And respiratory muscle training support should be done with diaphragmatic breathing exercises and expiratory muscle strengthening. So coming to dysphagia, this is one of the most important thing that is missed out. Do expiratory muscle strength training. Teach the patient of safe follow maneuvers like chin tuck posture, which is done by most of the patients. And Mendelssohn maneuver is nothing but ask the patient to swallow. We see the larynx rise. Advise to hold the larynx and swallow, and then leave the larynx. That is the Mendelssohn maneuver. It reduces the risk of aspiration. And texture and fluid modification with thickening of fluids. There is a product called thickener that can be used to make the fluid more viscous so that patient can drink water without aspiration. And oral motor exercises are tongue range of motion exercises and resistance exercises, lip sealing, and jaw range of motion and Masako maneuver. Masako maneuver is nothing but ask the patient to clench their tongue between the 2 teeth like this and advise the patient to try and swallow their own saliva, not with any fluids or food in the mouth. And postural and pacing strategies have also been taught. So these are some of the exercises. I don't want to go into that. These are hurdle exercises. So after 2 weeks of therapy, what is happening? So this is the post therapy scores. The TUG score, the timed up and go score was reduced from 27 to 21. The freezing of weight was reduced from severe to moderate, that is from 17 to 9. The UPDRS 3 scale reduced from 43 to 23. And the mini best test for balance, the score increased, that is from the high fall risk to moderate fall risk. The dysphagia burden reduced by 8 points. The voice handicap has halved from 24 to 12. So these are the patient's own score sheets after this. And what is the follow-up and retention plan? We have advised the patient to do daily home program. Caregiver queuing has been taught, self-monitoring, and reassessment after 4 to 6 weeks. So this is the final slide. So this is the baseline gait of our patient. So this is our gait pattern post-rehab. Can see patient is also doing dual tasking. He's able to adjust his clothes. The pivoting is reduced. His arm swing is improved. And you can see how confidently the patient is walking. And thank you. And I would like to thank all my therapists because my role was nothing. The levodopa doses, the levodopa equivalent doses were not changed throughout the course of the treatment. Just for 2 weeks of proper priming with RTMS and proper rehabilitation, we are able to see the improvement. Just a minute.
Thank you. Thank you very much, Dr. Arun Shivaraman, for the.
And I would like to take the opportunity of 2 minutes from the session to invite you all to IFNRCon 2027. It is happening in Coimbatore on April 2, 3, and 4. Kindly book your dates. This is just a teaser for what is going to come in the next year. Thank you. And I thank my mentor and my teachers and NeuroRehab Subsection for this opportunity. Thank you. Thank you.
Battery is low. Battery is low.
Thank you, Dr. Arun Shivaraman, for the wonderful case discussion. And before we go to the next topic, I request few words of wisdom from Dr. Nirmal Surya, sir, in comments.
Thank you, Guhan. We heard two lectures. The lecture from Abhishek, who highlighted the importance of gait analysis and specifically evaluating and then treating as per the merit. And there is a question also for you from one of the OTs, and I'm sure you will be able to guide that on that note. And Guhan, then Arun has presented a wonderful case. He has highlighted how to evaluate the case, what are the various scales, and I'm sure many of us neurologists know everything, but we do not do them routinely. And next time, I would also suggest that during the case, when you present a video, you should ask a poll that what sort of gait is this? How do you treat this? So, or what are the scales would be benefit? And then discuss about that so that audience also are interacted. And if they know, it will be fantastic because they would get a lot of confidence. So Arun, you were presented a wonderful case and also not only presented, you shown how the case can be treated. And this is where the evaluation and the management is important. I'm sure a lot of questions are coming. I don't want to take a lot of time and move on to the next talk.
Okay, thank you very much, sir, for the kind words. And now we come to the third talk of the tech session, and that's the most important to what we do. Gone are those days where we can subjectively say that the patient is improved and objectively confirm that the patient is improved. What is most required is to measure the improvement before and after our intervention. And many a times we talk about scales, but talk about numbers too, but we fail to understand what goes into the scale and how do we handle our scale, because how do we handle it is what matters the most. And for that, please welcome Dr. Hitav Someshwar, Assistant Professor of Physiotherapy at TN Medical College in BYL Nair Hospital, Mumbai, to talk on Berg's balance scale. How do I do it? Over to you, Dr. Hitav, sir.
Thank you so much, Guan sir. I'll just be sharing my screen now. Uh, this has been a wonderful platform and a brilliant opening innings by uh, the stalwarts in the field of neurology. And I'm here just trying to make a small difference. I would like to thank the Indian Academy of Neurology for inviting me, Dr. Guan for inviting me. And it's a pleasure to be presenting in front of my mentor, Dr. Nirmal Surya. Sir, please forgive me if I make any mistakes. So coming straight ahead to what is the work balance scale? The work balance scale, when we talk about it, it is the most widely used scale, but there are evidence that says that it is the most brutally used scale, and with a lot of mistakes, the inter and the intra-rater reliability of the work balance scale becomes an issue. So that is what we are going to now discuss over here. And what are the overview of the work balance scale? It is a 14-item scale. It takes less than 20 minutes to administer for both new and experienced clinicians. The scale rates from 0 to 56. It's a 5-point ordinal scale per item, where 0 is cannot perform and 4 is independently performed. It is a clinician rated outcome measure where you have to assess the static and the dynamic balance across sitting and standing. And as we mentioned, that BBS is a widely used evidence-based tool for assessing fall risk in neurological patients, including stroke, Parkinson disease, Huntington disease, and other older adults that we generally see the scale in. So now moving in, before we start with what do we do, why do we do, and what, these are the equipments that are required. You need to have a stopwatch. This is needed to record time, because there are certain items in the scale which are time based. You need chair with armrest as well as chair without armrest, and it should be at a height of 18 to 20 inches. A step stool is necessary. A ruler for measuring certain things such as the forward reach, which is the item 8 scale. And the most important thing that we in our clinical practice miss is the slipper or the shoe that we need. You cannot substitute this. I had a few of my residents and a few of my undergraduate students coming and telling me, sir, the slipper and the shoe, can we just do it with a tissue box because that is generally available with us? I said no, because there is a certain way in which the scale has to be done. And what happens is, today I am taking it, tomorrow a colleague of mine, if I send the patient to say Guan sir, and Guan sir does it, and then Guan sir will see that, the scale score is different. I think Hita's not done it properly. Or, I am doing it right, or I'm doing it wrong. There is always a doubt. And that leads to an intra-rater and an inter-rater reliability issues. So at this platform, I would like to say that the slipper or the shoe is an important thing. You cannot replace it with anything other than that. Coming to the next one, the scoring system, which is very important for us to understand. It ranges from 0 to 4, where 4 is the highest, where they can independently do the task safely within the time criteria that is there. In 3, it is they need supervision. Then 2 is they need to do it in a modified manner, or they needed supervision, or they needed some assistance. And in 1, when we score 1, it is minimal assistance, where they needed a physical assistance because there was a risk that they would fall. And 0 is when they cannot do it at all, or they need maximal assistance. So it goes from 0, 1, 2, 3, 4. It's based on a Likert scale that is there. It's an ordinal scale which we need to understand when we are doing research on this. So you have to mark the lowest category that applies to the patient. Do not be generous and give them 4 out of 4 for everything. Mark that score which is lesser if you had to do supervision. And points are deducted for supervision assistant or exceeding the allotted time that is there. Supervision required when excessive sway or safety concerns are existing. An assistive device should not be used at all. If the patient cannot perform without the assistive device, score it 0. Do not say that with assistance, the patient could do it independently and I'm scoring 4. No, it has to be completely 0. And a max score that is available is 56. That is when all 14 items are scored 4 points, or it is 0 when all 14 items are scored as 0. Now coming to part 1, which is basically in the static frame, in sitting and in standing. Those are the items 1 to 7. You are going to do sit to stand. You will have to tell the patient not to use their hands. Then we are coming to standing unsupported. Then sitting unsupported, where the back is unsupported, the arms are folded and they have to maintain that position for 2 minutes. Then from standing to sitting, because we want to check for the controlled descent into chair with armrest. That is an important thing. Then transfers, pivot transfers in both directions is necessary, and one surface with and without the armrest chair. So that is why we need 2 chairs, one with armrest and one without an armrest. You need to have standing with eyes closed. That is for a 10 second. This thing, the safety concern, if you think your patient is swaying a lot and you need supervision, you have to score it accordingly. Then standing with feet together, that's a 1 minute hold thing. The heels and toes as close as possible. In certain obese patients, in certain patients, when it is not possible, you need to give that lower mark of 3 instead of a 4 for them. Then coming to the other 14 items, that is the part 2 from 8 to 14, you need to go. These are the dynamic components of the balance test that we are doing. We are telling them to reach forward. The arms are at 90 degrees and you measure the forward lean and not a trunk rotation. You can't have the patient go over here and then go straight. You know, our patients want to be overachievers. They want to do that test better. You need to see if there is any trick movement that is happening. It has to be a pure, clean, forward lean. In my practice, I see to it that I click a photo and I see where the patient is there. And then it is pick up an object from the floor. This has to be a slipper or a shoe, no tissue boxes, no compass, nothing of that sort. Please see to it that it's a slipper or shoe. Then turn to look behind. Again, it has to be done both on the left and the right side. You have to turn 360 degrees also, again on both directions, from the right and the left, and then you give an average for 4. Suppose if it takes on the left side and if it is 3 on the right side, you will rate it continuously at 3. You won't give the higher marks, you will give the lower mark that is there. Then alternate foot on stool. Again, you're going to do the right and the left, and you're going to again score. If the non-affected side is going to be 4 and the affected side is going to be 2, you have to give the non-affected side, which is the lowest score. You cannot say 4 plus 2 equals to 6, divided by 2 equals to 3. Let me give 3 marks to the patient. We are not here. We are not being, extra helpful to the patient to give the scale out or to give them more marks. We don't want them to get a distinction score or a 90%. This is not what we want to do. Then tandem stance. Again, tandem stance or foot ahead. Demonstrate both options to the patients, where they can stand both front and front or onto the side, depending on how the patient is. If it is not possible for obese patients or patients with certain other physical abnormalities, you can have it at side to side, but there is an option for remark where you will be mentioning that the foot was ahead rather than in tandem position. And then a single leg stance. The patient will self-select the leg. You are not going to prompt it. And if it is a unilateral thing, please see to it that after the patient has self-selected it, you're going to do it on the affected leg as well. When there are unilateral disorders such as stroke, you will want to do it on the affected length. And then if it is greater than 8-10 seconds only, you will score it as a 4. And no contact should be made with the patient, that I'm going to hold his pelvis to see that he doesn't fall. Be there to supervise, and if you're supervising, it has to be scored at 3. All right. So now coming to the score interpretation, which is very necessary for us, which gives us a clearer idea as to how and what do we have to do. A 0 to 20 tells us that it is a very high fall risk patient, wheelchair level assistance likely is required for them. 21 to 35, they have a high fall risk, significant balance impairment, supervision is essential in these patients. 36 to 40 is a moderate high risk and nearly 100% fall risk in older adults. And 41 to 50 is a moderate risk for them. And 51 to 56, there is a low risk, but they are having independence, balance, maintenance, and prevention focus is what is necessary. The cutoff scores here, what a learning point is, since we are in the NeuroRehab Pathshala, you have to realize that the cutoff score should always be interpreted alongside a complete clinical evaluation. The individual context does matter, but it has to be with in collaboration with the clinical assessment. A patient with a 51 score with a poorer prognosis or a poorer outcome on a clinical evaluation is not the same with a score of 51 with a better outcome in the clinical evaluation in terms of the strength. So, one size does not fit all. So you need to start correlating it with your clinical approach as well. Coming to the next, what is the reliability and validity of the Berg-Balin test? It is reliable, it is valid, but one point that I want to make sure over here is there is a limitation to the scale. The fall risk prediction alone is weak. It is not reliable when you do it alone. So you need to do it with an other fall risk scale that is present, specifically in older populations over the age of 60 years old. And this is the link which is given down. We are going to share the PPT with you in the group that is formed, and it has all the links because we believe in an evidence-based practice. And the test retest reliability, the intra-rater reliability, it is good for tele-assessment also. And it is used when you compare it with Barthel index also, there is a strong correlation, and the validity is concurrent and divergent as well and convergent as well. So we need to know that the scale has been used properly. But you know what? This reliability and validity is taken into context from the verbatim. Verbatim means whatever is written in the scale as to what should a therapist or what should a clinician tell the patient when you exactly say the same way. The scale has been translated into various languages. In our Indian languages also, like Hindi, Marathi, Gujarati, Tamil, Bengali, Malayalam as well, even in Urdu. So whenever you're using it for a person who does not understand English, take the translated thing, because what you tell, what advice do you give to the patient will have an effect on your score. And this has been proven with literature also. So the reliability and validity which I have shown over here is based on when you use the scale correctly. When you have used a stopwatch, when you've used a slipper or a shoe and not a tissue box, is when you're going to get this reliability and validity. So now coming to two important things, since this was the first NeuroRehab Pathshala, it is always important for us to put out those two things, that is the MDC and the MCID. So the first one is an MDC, that is the minimal detectable change, which says that the minimum change that exceeds the measurement error, that is the statistical threshold of a particular scale, is very important for us to know, because you need to know whether this importance is clinically significant or is it statistically significant. These are two things which are very important. And that is when it comes is an MCID, that is minimal clinical important difference. So when I say that this is perceived by the patient or by the therapist as an important change in his structure, in his activities of daily living, or in his present condition. So always remember that every scale that we take, we need to know what is the MCD, that is the minimal detectable change, and we need to know what is the minimal clinically important difference that is there. I have listed out this based on the evidence that is there. For stroke, what is the MDC in the acute and in the chronic, for the Parkinson's disease, for the Huntington disease, and in elderly as well. I'm going to share this scale with you and all the literature with you, so you all can go for yourself and realize, and this has been there at a lot of platforms. So it is important for us to understand this. Now, a few administration pearls which we have been spoken in the past also. This is what we practice in our practice at our institute and in my private practice as well, is we read the instructions every time. I am not someone who has by-hearted it. I have the scale in my hand and I read every sentence to my patient, so everyone understands the same way. And this has been proven by a lot of literature that is coming around. And paraphrasing, especially the shortening the cues, is one of the most common sources of inter-rater variability, which we do not want. You have to demonstrate it, don't just describe it, because how they perceive what you're telling is different, because we have patients with aphasia and apraxia also that we generally deal with in our day-to-day practice. So I make it a point of demonstrating everything, even if the patient is cognitively sane and is able to understand what I'm trying to tell them. Now, the scoring errors, there are the static items that they do where the sit to stand score the hand use and not the smoothness. Even if they are not using their hands and they can do it better, give them a 4 on 4. Do not score it based on the smoothness. They did it fluid like, or they did it with jerks and they did it with. Please do not go into that. Unsupported standing, don't stop the timing early. Let the patient sway or have a stepping strategy that is there. Then only score it. Otherwise, wait till that happens. The eyes closed standing, a light fingertip on a wall counts as support and drops the score. Always remember, or a small touch by the therapist at the back of the patient is also a thing. I have patients who tell me, sir, wo thoda haath laga ke dijiye na, it feels better and I know there is someone there. But that time I'm not scoring them 4, I'm scoring them a 3 because there was supervision that was involved. Scoring errors for the dynamic and reach items, again the forward reach, measure with a ruler, do not estimate. No trunk rotation should be allowed. Turning to look behind, the weight shift should be equally, not just the head turn. The patient has to turn 360. Alternate step, count reps actively. Fatigue causes drop off in final steps, so wait till the last step that is there and then only score them. And respect the time limits, they are not optional. The scale said that you have to see them. Several items have explicitly time ceilings, that is the tandem stand, the single leg stance, and the step item. So everywhere going beyond them to give the patient a chance, it invalidates the standardized score because the patient might get fatigue. If there is a 10-second, stop at that 10-second. Do not go that, oh, my patient can do it for 30 seconds and I'll put a remark over there. That does not tell me, that does not give them a distinction or an honors degree over there. So that is what we need to be very clear over there. And again, the space requirements that should be there, do not do it in a busy OPD. See to it that you have a 3-meter clinical area that is there for unobstructed walking space. No rugs or trailing wires around, because these are the common silent co-founders that artificially lowers the score. In a busy practice in a government institute like us, it is very difficult to do this. It is better not to administer the scale rather than administering it wrong. The chair placement standardizes between the 2 sessions. So whichever chair you have used today, please use it after 3 weeks as well. So always have the chair fixed on what you're going to do. The footwear and clothing should always be there. No socks alone, not with unfamiliar shoes. If they are okay with wearing barefoot, they have to do it with a barefoot. If they are wearing those slippers which slip out, the bathroom slippers, make them wear those only. That is what is going to tell us their actual balance level. So document the footwear that is used, and if it changes between the 2 sessions, then also it can affect your score. If you are doing the ankle foot orthosis, document if they are worn and test consistently. So if they are wearing an ankle foot orthosis in today's session and in 6 weeks later, if I'm going to do the Berg balance scale, see to it that the same ankle foot orthosis is there, or mark it over there saying that this can be a disclaimer that the ankle foot orthosis has changed, or the fitting has changed, or the design has changed. That is why the score would have changed. Okay, safety and during testing, we don't want any of our patients to fall. So see to it you are there to give that supervision. Keep 1 or 2 other helpers to be there. The verbal or tactile cueing during time task changes what is being measured. So keep your mouth shut. Do not let the therapist or do not let the students also speak to them, or the relatives speak to them, where they will say, Papa, do it better, or uncle, do it better. Nothing of that sort. It has to be there. Whatever the clear instructions are there, those are the things that have to be there. Document any safety intervention that was done, and instead of a 4, come down to a 3 or a 2 if you have given any safety during these tests. Document deviations that were there, and these details makes the reassessment meaningful. So when the BBS hits limits, like your share market, there is an upper circuit, there is a lower circuit. So if there is a floor effect when the score is 0/56, that means we have done a wrong scale for them. So switch to the trunk impairment scale or a function in sitting test or a postural assessment scale for stroke when you're doing it for stroke patients. Do not say it is 0/56 because at the 6 week time also you're going to get those. So you're not able to do that. That is when you've used the wrong scale in your patient. And ceiling effect. Suppose if you are going to do work balance scale in me because they say it is valid from 18 years to 100 years, that does not mean that you're going to do it in me who does not have balance issue, because that's when a ceiling effect is there. So that is when, like Dr. Arun also said, there is a mini best test or the best test score, and then there is a dynamic gait index or the community balance and mobility scales for people who score 56 out of 56 in certain scales, and you know that this is going to be a ceiling effect. So if a patient is pinned at the floor or ceiling, change the scale. It is not for the outcome measure. The swapping the scales is a clinical decision and not a failure of BBS. Please know that. How often should we re-administer the scale? For different conditions, it is different. Generally, in an acute stages, do it weekly. In the chronic stages, do it 4 weekly. And depending on the progression of the disorders as well, the guidelines have been given. We'll be sharing these things with you as well. And BBS across special population in stroke, it has been known in Parkinson disease and Huntington disease, and in older adults. It has been used in various other diseases as well, but the evidence is poor in them. And the common questions that are there: can the patient use their walker and cane? The answer is no. Patient can't stand. Do I still administer the BBS? If it is going to be 0, then you want to go and check that it is going to hit the floor. So you want to change your score. Which leg for single leg stance? If it is a unilateral disorder, use the same leg which is affected. Can I hold a gait belt during testing? No, please. No zipper wearer. Can I use a tissue box? Straight away, no. Patient loses balance in tandem score, auto score 0, no. Demonstrate both on tandem and foot ahead options, and that is when you will be able to score them better. Again, a small scale, a scale where we are saying that why is it important to see the MCID? Because from 0 week to 4 weeks, there was a +9 points, which exceeds the MDC score. So this is the real change that is seen in the patient. I'm not saying that it is only a statistically improvement. It is a clinically significant improvement that is there. But the same way, when we go into a scale where when we are doing it into a neuroregression scale or a progressive disorder, that time when we say that there is a change of 3 points, which was from month 0 to month 3, there was only a change in 3 points, but it does not change based on your MDC for the Parkinson disorder. So this is within the measurement error. So you cannot confirm a true decline. You cannot say that my patient is deteriorating. So you have to wait. Now you're going to do it at the 6 months time when the change is happening at 6 points. So this changes from your minimal detectable change of 5 points. So this says that there is a real decline that is confirmed. So the regression is meeting your threshold. So this is what you need to understand. And if it crosses your MIDC, then you're going to say that it is a pattern of progression because of the disease. So you need to go and visit your neurologist, or you need to go and change your therapist in a particular way in terms of whether are we going in the disease is changing, or has the medication changed, or both have been causing this neuroregression that is there. So when we call it, when the score drops greater than the MDC threshold, sustained across 2 consecutive assessments, and it corroborates by item level parameters and not only a single scale that changes or a single point that changes, and it has to be contextualized against clinical and medicational changes. Just do not overcall a regression that is there. And a number without context is just a number. BBS becomes only a clinical tool when you know what changed, by how much, and why did the change occur. So it is not just a number that we generally use. And this whole presentation has been made from an IFNR resources that has been done under the able guidance of Dr. Nirmal Surya. So everyone is welcome to visit the resources site, and in the view resources, you have to go on the balance. And the first scale that we have done over there is the BBS scale. The whole presentation along with all the references are available over there. I request everyone to visit the ifnr.org page, go to the resources, and please check this out, because the whole IFNR task force team has spent a lot of time to get this in one place so that all the resources are available. And I would like to take this opportunity to thank Dr. Surya to take this lead forward to get this in one place, and it is for an Indian context. So with that, my key takeaways are the same thing. Always use it finely. See to it that the timing does matter. Do not be over calling a diagnosis or over calling a regression, and always follow the rules that are set by the person who has made this. With that, I would like to end my presentation. I'm sorry, Dr. Guan, if I have overcrossed my time by a little, but it would be good for our participants. Thank you.
Thank you very much for the mesmerizing talk, Hitav sir. The participants would have wanted more from you. And with that, we can come to the end of the measure talk. And I'm sure that was very enlightening and enriching to all our participants. And we have 4 questions and a message from the digital team that we are running out of time. So we'll take these questions shortly. Our first question is to Dr. Abhishek sir. What can OT do when an abnormal gait pattern affects functional task? Do we teach them compensation or address with ADL?
It's a good question. I think it depends on the disease chronicity. For example, if it's a stroke, if it's acute subacute stroke, patient can still change and recover. There's a compensation or remediation, there's a compensation, there's a concept of compensation. We published long back, 20 years back, that many stroke patients who were non-ambulatory, if they get good training, 1/3 learn to walk, even 2 years, 3 years post-stroke. So always keep in mind, all of us assess, does that patient has a rehab potential to improve? If yes, focus on that. Try to make him better, treat the impairment. If you can't, then we'll try compensatory strategies. Otherwise, many times we only focus on the disability, we forget the impairment management.
Thank you, sir. And the second question is to Dr. Arun Shivaraman. With PD, do you think LSVT big protocol with RTMS will help?
Definitely. LSVT big protocol will definitely help. In this patient, we didn't discuss about LSVT big in per se, was because the patient has predominantly postural instability and gait dysfunction. So we concentrated the rehab protocol based on this patient, but definitely LSVT big definitely will help the patient.
And only rehab without RTMS, what is the improvement? Any data?
So the data is there all along, but RTMS is a new one. It primes our cortex, and definitely, see, the PT is a bottom-up approach. We move our limbs, we make the patient move, and we recirculate the pathway. The RTMS is a top-down approach. We stimulate the cortex with magnetic stimulation, and we prime our cortex for physiotherapy. So even without RTMS, definitely PT will help.
I must say here that all these years we have been treating the patient with therapy. RTMS can only change in those patients where physiotherapy is not helping, or very severe disabled patient. Many times they don't even cooperate, or those who tends to fall, and so that's where the RTMS is going to change the outcome. But don't think that if you don't have RTMS, you or your patient won't improve. So that concept is wrong. I think physiotherapy is important. It is right up to you which are the, out of all the cases, 100 patient, not 100 require the RTMS. There may be 10 to 15% patient where it is important. So please don't take it that RTMS is a must for everybody.
Thank you, sir. As I definitely said, it's been hundreds of years that physiotherapy is our golden arm, but without RTMS just helps the physiotherapist. It does not replace the therapist.
Okay, and how do you measure progress in PD as the disease progresses?
We have the MDS UPDR scale. UPDR scale is there. Unified Parkinson Disease Rating Scale is there.
Okay. Thank you very much. And I request few words of wisdom from Dr. Nirmal Surya, sir.
I think we need to finish things in time. So Gohan, next time try and keep all the three talks, case, and scale within say 65 to 70 minutes, so that you have enough time for discussion.
Yes, sir.
We want audience to engage. Add some poll questions into the talks and in the case, and also at the end of it, we can discuss more with the discussion, because it is what we are. Pathshala is more of a communication, more of a asking, more of a putting the thing across the student. But in that, our thing has started very well, and I must congratulate all the speakers to really bring it down, particularly the Hita, who has put up the skills so well, which neurologists haven't listened for very, very long time. So Berg balance scale is a very, very important thing. Hita, don't miss out on cerebellar ataxia. I did the pilot study with Berg balance.
Sir, the Huntington disease, sir, they have called it as cerebellar ataxia only, sir, because the evidence is based on that,
No,
sir. I knew
Huntington's is
you were
not
going to say
cerebellar.
that.
Huntington's is dystonia, rigidity plus ataxia.
But the evidence, sir,
Hello.
only one article, sir, from your end. So maybe we need more articles on the use in different case scenarios, sir.
Definitely. This is what we want people to take the research into, like this, of the various parts. So thank you very much, Guan. You can summarize. Abhishek is very much there. He can also put some words at the end.
Abhishek, sir.
You can I think it's a good initiative here in the subsection, and I hope that you continue this journey. One same point I'll try to say: finish all these talks. You can say 20, 12, 12. That's enough. So you have more time for discussion.
Okay, sir. Sure, sir. And three just house rules for everyone. This is the WhatsApp group. So anyone who's not in the group, you can join by scanning this QR code with your WhatsApp. And since we don't have time for the quiz, what I will do is that, because quiz is only for those who are attending, I'm going to show you the QR code. And before I show you the QR code, one other information is video recording of how the Berg's balance scale will be posted in the group by Dr. Hitav sir. He has the video ready, but due to time constraints, we have limited that. And this is the quiz QR code. Those who are here, scan it. By 9:10, the form submissions will close. So by 9:10, we won't be continuing this meeting, but the form submission will close, and only those who have submitted by 9:10 will be taken up for marking system. And with that, we come to the end of our very first episode together. Dr. Ramkant Yadav, sir, you would like to say a word in 30 seconds, sir?
Dr. Gohan, it was a great initiative under leadership of and visionary vision of Dr. Nirmal Surya sir, and I'm sure that this Pathshala will be very helpful for the neurophysician who are working in the rehabilitation also. So I congratulate whole of the team of the NeuroRehab subsection, especially Dr. Nirmal Surya sir and Abhishek Srivastava, as well as Gohan Ramurthy. Thank you very much.
Thank you very much, sir. And we come to the end of our very first episode together, but I do not think of an ending at all. I think of it as a first step.
Share
And
the
we
code again, somebody else.
Okay, sir. And let me give thanks to our presidium, our president, Dr. Lakshmi Narasimhan Ranganathan sir, our president-elect Dr. Sudhir Kotari sir, our secretary Dr. U. Meenakshi Sundaram sir. Thank you for blessing and for believing in us before we had earned it, sir. And most importantly, to a mentor, to a guide, our chairperson, our Dr. Nirmal Surya, sir, we thank you, sir. We are walking the very path you cleared for us, and we will keep walking it long after tonight under your guidance forever. And to our three faculty, Dr. Abhishek Srivastava, sir, who has been showing us the way, Dr. Arun Shivaraman, and Dr. Hitav, sir, Someshwar, sir, for their energetic talk. You gave us your evening, your wisdom, and your hearts. Thank you from all of us. And to you, every one of you, more than 600 across 13 countries, thank you. Do you understand what you have done tonight? It is a NeuroRehab Pathshala that we have started today, and we will return next month after month, until we make sure that the knowledge of Neuro Pathshala spreads across. Until then, on behalf of Neurorehabilitation Subsection of the Indian Academy of Neurology, thank you, good night, and never ever let the lamp go out. Thank you, sir.
Good night, everybody.
Thank you. Thank you.